Transcatheter aortic valve replacement with a balloon-expandable valve in low-risk patients. Definition: the bicuspid aortic valve disease is the most common congenital heart defect and the leading cause of aortic stenosis requiring valve replacement. The although most cases occur in the calcified valve, separate aortic stenosis can occur in the EVAV when there are thick valve and the fibrosis without calcium. And this more common in younger patients. The presence of BABD and the absences of calcium in the aortic valve are contraindications for RPBA due to the possible risk of valve displacement.
The transcatheter aortic valve replacement procedure is performed on patients who have severe calcified aortic stenosis. And here you see an aortic valve that's not opening well. It's severely calcified and the leaflet motion is restricted. So to perform the TAVR or transcatheter procedure, a wire is inserted in the femoral artery. It is threaded up through the aorta and around the aortic arch. And then that wire is passed through the stenotic aortic valve and placed in the left ventricle. Following that, a balloon catheter is passed over the wire into the stenotic aortic valve. The balloon catheter is then inflated, opening up the stenotic valve, cracking the plaque, and freeing up the leaflets. And that's in preparation for the stent valve or the transcatheter valve to be inserted. And the first rendition that you see is the first stage of the catheter going in, and then the second stage of the catheter coming through around the aortic arch over the wire, and it's going to insert into the stenotic valve. Once the catheter is placed in the valve, the stented valve is ballooned open, pushing the diseased leaflets out of the way and leaving a functioning aortic valve in place. And then the wire is removed, and you can see the leaflets of the aortic valve opening and closing, providing normal flow through the valve. The TAVR procedure, the transcatheter aortic valve replacement, is revolutionary.
The application in medicine, the conventional surgery for the aortic valve disease continue to be the gold standard with the very adequate results in the relation of the preoperative risk present. In the individuals with the severe aortic stenosis, 30% of them have a very high surgical risk for conventional surgery. This group mainly includes elderly patients who should avoid the type of surgery. And the extracorporeal circulation is also avoided with the secondary effects.
This is an animation showing transcatheter aortic valve replacement through the transfemoral approach using the Edwards SAPIEN 3 transcatheter heart valve. The heart's main function is to pump blood to the rest of your body. The heart contains 4 valves. Normal valves have 2 or 3 flaps of tissue called leaflets that open and close like gates to control the flow of blood through your heart. It's important to know that if you have aortic stenosis, your aortic valve narrows due to calcium buildup. This prevents the valve from fully opening, which blocks blood flow from your heart to the rest of the body. As a result of the reduced blood flow, the body does not get the oxygen it needs, which can lead to symptoms. Aortic stenosis is a progressive disease, which means it gets worse over time. It's typically measured as mild, moderate, or severe. The only effective treatment for severe aortic stenosis is to have your aortic valve replaced. Today, there are two options for replacement: open heart surgery or less invasive transcatheter aortic valve replacement, also known as TAVR. During the TAVR procedure, you may be placed under anesthesia. Once under anesthesia, a small incision will be made in your leg, where your doctor will insert a short hollow tube called a sheath into your femoral artery. Sometimes, as a first step during the TAVR procedure, balloon aortic valvuloplasty, also known as BAV, is performed in order to open your narrowed calcified valve. Once the sheath is in place, your doctor will guide a catheter with the balloon on the end of it up to your aortic valve. Once the balloon catheter reaches your aortic valve, the balloon is inflated to open your narrowed calcified valve. The balloon catheter is then deflated and pulled back from the aortic valve. During the next step, your new transcatheter heart valve is crimped onto a delivery catheter, which makes the valve small enough to fit through a sheath, so it can be delivered to your heart. Using a special type of X-ray, your doctor will guide the delivery catheter carrying the new valve through the sheath and up to your aortic valve. The balloon of the delivery catheter is inflated with fluid, expanding the new valve within your diseased valve, pushing the old leaflets aside. The balloon is then deflated and the delivery catheter is removed, leaving your new heart valve in place. The frame of the Edwards SAPIEN 3 transcatheter heart valve is strong and will use the calcified leaflets of your diseased valve to secure it in place. Once in place, the SAPIEN 3 valve begins functioning immediately, with the leaflets opening and closing to pump blood to the rest of your body. The most serious risks of the TAVR procedure are death, major stroke, major vascular complications, and life-threatening bleeding. If you or someone you know has severe aortic stenosis, only a TAVR heart team can determine which treatment option is best for you. Ask your doctor to refer you for a TAVR evaluation. To find a specialized heart team at a TAVR center near you, visit newheartvalve.com.
The ICU applied in Ecuador, the clinical cardiology unit and the surgery area of the Hospital Teodoro Maldonado Carbo since 2550 implement a new producer, transcatheter aortic-valve replacement for aortic stenosis. The doctor in this hospital only have one type of valve for the intervention with the TBR, which the core valve.
Welcome to our program highlighting research manuscripts from the Cleveland Clinic Cardiology Fellowship. I'm Venu Menon, the program director as well as head of the section of clinical cardiology. And with me today is Chetan Huded, our former chief fellow and currently an interventional fellow in our section. And Chetan's come out with an extremely important paper in JAMA highlighting outcomes in terms of stroke after TAVR from the TVT registry. So Chetan, first, congratulations on having a first author JAMA manuscript as a fellow. I just think it's terrific. Tell me a little bit about the hypothesis and the rationale for why you explored the TVT registry in this manner.
Thank you so much for having me and for that introduction. So this project really was born out of our recognition that here at the clinic, we see that TAVR is a complete blockbuster. It's completely changed the way that we treat valvular heart disease, specifically AS. And TAVR is maturing now to the point where it's a fairly advanced procedure. The procedure was FDA approved in 2011. And as you can see in the slides, over time, the clinical trials of TAVR devices have suggested that the stroke rate after TAVR has declined. And stroke is a major complication. In the early trials, in the partner trials where TAVR was just coming out, the stroke rates are about 5%, and it was a concern initially that, is this going to be an issue with the procedure? But over time, the clinical trials have suggested stroke rates as low as 1% or less more recently. And so I think people in the field generally believe that post-TAVR stroke is decreasing. The devices have gone from first generation to second generation, now third generation devices, smaller delivery profiles, operator experience is better. And so I think it's a natural hypothesis that the risk of stroke after the procedure has probably gone down. But that's never been shown that in practice that that's the case. And so we had a very simple question, which is that in the United States, in the first 5 years of the experience in the United States, has the stroke rate changed? We would expect that it would with all of the things I mentioned, but nobody has actually shown that that's been the case.
So tell us about your findings.
So we used the TVT registry to answer this question because I think it's really the only way you can adequately address the question that we had. The TVT registry is really nice in the sense that it's a collaboration between the American College of Cardiology and Society of Thoracic Surgery. The registry is set up in such a way that every procedure, every transcatheter aortic valve done in this country is essentially in the registry because hospitals must participate to be reimbursed for the procedure. So everybody's participating. So in our study, over 500 hospitals in the United States. And we looked at, since FDA approval of TAVR until the time we conducted the study, which was about a 5+ year period. And we said, we've decided to focus on 30-day stroke. Now, there's, of course, people talk about long-term risk of stroke and these things, but we've done some background work that suggests that after about 30 days, the stroke risk goes back to background risk. So we wanted to focus on procedural stroke within 30 days. And we said, let's see what the stroke rate has done over time. That's the first question. And the second question is there anything that we're doing in terms of medical therapy that's associated with that risk? So the next slide shows that the risk of stroke is about 2.3% within 30 days of TAVR. The majority of that risk temporally is early, within the first 3 to 4 days after the procedure. Most of it is actually within the first 24 hours. And that the majority of those events are ischemic strokes, not hemorrhagic strokes. And what we looked at next is, has that rate, 2.3%, gone down over time? Because that's really the pivotal question. And what you can see is that actually from 2011 really through 2017, when we sort of closed the data set in this study, that the rate is extremely stable. And the p-values aren't shown, but the p-values are all not significant. So the rate of stroke after TAVR in the United States in clinical practice has not changed, despite the fact that the valves are getting safer, the operators are getting more experienced, and hospitals are getting more experienced. The stroke rate has been stable. Now, 2% is lower than what we see in clinical trials, and this study is, as I mentioned, based on a registry, but in the registry, the events are self-reported by the operators in the hospital. So there's always a concern about underreporting of events, and that may be one of the biases in this study. But irrespective of that, the rate itself is stable. So temporarily, there has been no change over time.
Now, obviously, over time and in the near future, we're going to be doing TAVR in low-risk patients. So do you think that this stroke risk is a function of patient risk or procedure risk? Because obviously a 2% risk in a 90-year-old is very different from a 2% risk in a 65-year-old. Do you have any insights into that?
It's a phenomenal question, and I think it's what's on everybody's mind, is that as we start doing TAVR in lower risk patients, a risk of 2% is probably unacceptable, in a low risk patient in which the surgical mortality alone should be less than 1%. And so this data, in that sense, does not address that in the sense that, at the time of this study, TAVR has only been commercially approved for inoperable, high, or intermediate risk patients. So low-risk patients really are not included here for the most part. But, the most recent trials on low-risk patients suggest that the stroke rates with TAVR are fairly low. Now, we need to prove that in clinical practice. I think that's the next phase, is to say that now that, as the bar moves towards lower-risk patients, can we show that we're achieving the same bar in clinical practice as we've demonstrated in clinical trials. And I think our study highlights the importance of proving that we all thought that stroke risk was going down because the trial suggested it, but the practice has not caught up.
And the other question I had, Chetan, was, obviously there's been data.
The pros and cons, the pros, the TAVR, the replacement valve generality function better than valve used in open heart surgery. The recovery post TAVR is much easier than the open heart surgery because there are no large incisions in the chest. The cons, the blood vessels complications, the kidney disease, the problems with the valve itself, the stroke, infections.
Transcatheter aortic valve replacement, or TAVR, is a minimally invasive heart procedure aiming to replace the narrowed and diseased aortic valve without the need for open heart surgery.
You would be a candidate for TAVR if you have severe aortic stenosis, which is clinical speak for severe narrowing of your aortic valve.
Generally speaking, if they have symptoms as well, shortness of breath, chest pain or chest pressure, dizziness, fainting, or all kind of classic symptoms.
They used to be able to walk to their mailbox and back, and now it makes them so short of breath they need to stop and rest before, or their energy level has really decreased. They're not able to have the quality of life that they thought they should be having at this age, or they have definitely noticed that it has decreased over 6 months to a year, sometimes longer.
The new valve is delivered into the body through a catheter that has the valve mounted on it. The delivery system enters the body through a needle-sized cut in the groin or through other areas in the chest in some occasions.
Thread it up through the aorta, your large, basically, blood vessel, and place it into the heart without opening your chest.
The new valve will be delivered within the existing diseased valve, where the new valve push the diseased valve aside and start to operate immediately.
One of the great advantages to TAVR over the traditional open heart surgery is that the recovery time is much different. Most patients are just here one night in the hospital and then return home the next day.
In 2011, FDA approved transcatheter aortic valve replacement for those who are at high risk for surgery. Today, we can perform TAVR in all patients who are at high risk, intermediate, or even low risk for open heart surgery.
The conclusion among patients with the severe aortic stenosis who were a low surgical risk. The combined the rate of death, stroke, or the rehospitalization at 1 year was significantly lower with the TAVR than with the surgery. Thank you.